So now I'm going to turn it over to Taylor, and she's going to talk about PCOS and aging. So Taylor, it is all you.
Sorry, I was still muted. Hi, everyone. My name is student pharmacist Taylor Leggett, and I'll be speaking with you today about polycystic ovary syndrome.
You took away your presentation, Taylor.
Sorry about that.
That's okay.
Here we go. Hi, everyone. My name is student pharmacist Taylor Leggett, and I'll be speaking with you today about polycystic ovary syndrome. So first, we'll start with our objectives. From this presentation, you should be able to understand what PCOS is and how it impacts healthy aging, recognize the symptoms of PCOS, describe appropriate pharmacologic and non-pharmacologic treatments for PCOS, and develop a patient-specific treatment plan based on the case presented. So first, we'll go over our patient case. I have Ms. Crowder, who is a 63-year-old African-American woman who is dealing with PCOS. We also will go over the disease and what PCOS is. Then we'll talk about the diagnosis, some signs and symptoms that patients should be aware of. And then we'll talk about pathology, what causes PCOS, treatment, what is the best way to treat our patients, and then we'll tie this all together by going back to Ms. Crowder. So let's start with our patient case. So Ms. Crowder is a 63-year-old African-American female who presented to our women's health clinic complaining of frequent hunger, urination, and thirst. And she's having this 2 to 3 times per week, and it's causing her significant discomfort. Her HPI is that it's increased over the last 6 months. Some past medical history that we should know of about Ms. Crowder is that she was diagnosed with PCOS at age 27. She is married, she has 3 children, and she taught elementary school. She's currently taking spironolactone 25 milligrams daily, and her vitals and labs we'll go over a little bit later, but she has had a mammogram, which was negative, and her physical exam was unremarkable. So about the disease. So according to Johns Hopkins Medicine, PCOS is a condition caused by abnormal production of androgens by the ovaries, which is normally present in small amounts in females. How is it diagnosed and what are our signs and symptoms? Patients who have PCOS, they may have increased irregular periods. So with irregular periods, it's not just that they aren't happening like on your scheduled time that you think that they're supposed to happen. They could be absent completely, they could be infrequent, or they could be too frequent, so happening more often than they should be, multiple times per month. They could be heavy, or they could just be unpredictable. So some months you have them and some months you don't. Patients may experience infertility. They also may experience obesity, but specifically abdominal obesity. So for our patients who have PCOS, they might have weight gain, but the one that we will specifically be looking at is in the abdomen area. They could have hyperandrogenism, which causes hirsutism, acne, as well as alopecia. And this is detected and diagnosed via a blood test that a doctor will do for our patient. They can also have acanthos nigricans, which is basically like a darkening of the skin, as well as like a thickening and velvety feeling. So you may have seen people who have this in their neck area or their armpits, as well as their groin. And lastly, the enlarged cystic ovaries, which is detected via ultrasound. So on our left here, you can see what a normal ovary would look like in a patient who does not have PCOS. And this is what they will see on an ultrasound as well. On the right, you will see what an ovary looks like if there is actually PCOS or several cysts present on the ovaries. And so these just look like small fluid-filled sacs. So how does this happen? One of the things that could happen for a patient who has PCOS is increased GnRH, which is gonadotropin releasing hormone, and that results in hyperandrogenemia as well as dysfunction in ovulation. There could also be insulin resistance that could result in increased androgen, weight gain, and type 2 diabetes. As a result of increased androgens from these other problems, patients could have menstrual abnormalities, acne, hirsutism, and body shape changes. And also it's important to note that genetics can cause this, as well as other chronic diseases. So their chronic disease thing is a little bit tricky because on one hand, a patient may have PCOS and that causes them to have some of these other chronic diseases. However, the symptoms that come with the chronic diseases also worsen the PCOS phenotypes that we see. These diseases include metabolic syndrome, diabetes, hypertension, dyslipidemia, sleep apnea, and endometrial hyperplasia. So how does this affect our other conditions or the conditions that we just talked about? We already kind of spoke about diabetes and how PCOS is caused by insulin resistance, and insulin resistance results usually in type 2 diabetes. Type 1 diabetes is a different kind of insulin issue that a patient can have. So like we talked about, a patient who has PCOS can be diagnosed with these issues, and these issues worsen PCOS. So hypertension, you are at increased risk for having hypertension with PCOS due to increased BMI, presence of metabolic syndrome, as well as insulin resistance. And this is the same for dyslipidemia. It's important to note that 70% of patients who have PCOS will be diagnosed with dyslipidemia as well. Metabolic syndrome is kind of a group of symptoms that you are diagnosed with, or phenotypes that you are diagnosed with based off of your body, your weight, your labs, and etc. So metabolic syndrome, you are at increased risk of getting this with PCOS, basically because of hypertension and dyslipidemia and weight gain that you commonly see with PCOS. So the 3 of the 5, you have to have 3 of the 5 criteria in order to be diagnosed with this. That criteria includes abdominal obesity, high triglycerides, reduced HDL, which is your good cholesterol, high blood pressure, and high blood glucose. So pretty much most of our patients are going to have the 3 of the 5 just based off of what we already spoke about. Next is sleep apnea, and this is increased due to weight gain. So as a patient has more weight, they have more issues with sleep. And lastly is the endometrial hyperplasia. And this is due to inadequate balance of testosterone and estrogen. And this eventually could progress to patients having issues with endometrial cancers as a result. So how does this impact aging? The long-term effects associated with cardiometabolic syndromes, we already kind of talked about these, but with hypertension and dyslipidemia and even metabolic syndrome, there's something called an ASCVD, which assesses the 10-year risk a patient is at for having an event. And so if you have these types of diagnoses like diabetes and the ones that we spoke about, you are at higher risk for having a cardio event, such as a myocardial infarction or stroke or etc., based off of these diagnoses and based off of your cholesterol and blood pressure, age, if you smoked, and what medications you're currently taking. Another one is that the hormonal imbalance does not change. So our patients may experience these symptoms lifelong. That's different from the other period related or menstrual related conditions that you usually see in women's health, because a lot of patients, if they have any menstrual related conditions after they go through menopause, these conditions are over. However, with PCOS, since this is something that really affects your hormone levels, not so much as estrogen, but more as testosterone and androgen, this is what's going to be causing those symptoms. And that's why our patients can experience them long term. And then there's that risk of endometrial cancer that we spoke about already. So what is our treatment for this? Our goals of treatment for our patients, and these are starting from diagnosis to the end of their life, is correct ovulation, improve infertility, maintain normal endometrium, decrease insulin resistance, reduce androgen effects, and reduce long-term complications. So our first line, basically treatment for PCOS, is weight loss. And that's difficult for a lot of our patients to hear because it is hard to lose weight. However, a 5 to 10% weight reduction will really significantly improve your symptoms associated with PCOS, because of hair and acne issues will be decreased. There's a decreased risk of having other issues such as blood pressure issues, cholesterol issues, and it also improves insulin resistance. So we want to let our patients know that they should adhere to a Mediterranean or DASH diet. They should really reduce their foods that are high in sugars, processed foods, having excess processed meats and things like that are really things that we should reduce for our patients, as well as adhering to the ADA recommends about 150 minutes of exercise per week. I know that in elderly patients, this may be a lot more difficult for them to adhere to. However, a good rule of thumb is just to tell your patients to work to the best of their ability and stay within their means of physical activity. However, doing resistance exercises and strength exercises and even a little bit of cardio like biking is a really good way to get that weight off and to help with diabetes. So let's talk about some of our second line treatments. The first is combined oral contraceptives, and this helps with the regulation of menses. However, this also can help with our patients post-menopause because combined oral contraceptives aren't just used for contraceptive purposes. The drugs that are in this medication is estrogen as well as progestin. Some of the risks of combined oral contraceptives, and these risks exist, and so I want to tell you about them. However, this does not mean that every patient that has been on a contraceptive will experience these. And so there's cardiovascular events that could happen, and hypertension, venous thromboembolism, glucose intolerance, cervical cancer, and breast cancer. Some of the absolute contraindications for starting this medication is if the patient has a history of venous thromboembolism or VTE, stroke, CAD, ischemic heart disease, or breast cancer. Also, if they have uncontrolled hypertension with a blood pressure of greater than 160/90, heavy smoking is a major one. So if they smoke more than a pack a day, or if they're even smoking more than 15 cigarettes per day, especially in women over 35, they're at increased risk of having complications with this medication. If they have migraines with a focal aura, this is something that they should avoid. And then thrombogenic mutations as well. Our next medication is metformin, and the purpose of this is to stabilize insulin. Most people think of metformin as the first line drug for diabetes, but this is also a really good option for PCOS because it will reduce insulin resistance, which reduces androgen production, and it will help establish irregular menses, improve infertility, and improve glucose tolerance. For this medication, the patient should be taking 500 milligrams 3 times daily, up to 2,500 milligrams. However, it's important to know that there's an increased risk of stomach upset. That is one of the major adverse effects. This drug can cause like nausea, vomiting, and diarrhea, especially diarrhea. And so if the patient is experiencing these symptoms, they may be switched to an extended release formulation to decrease those symptoms. A good rule of thumb, if you're starting patients on this medication, is to start low and go slow. Next is spironolactone, and the purpose of this medication is to work as an anti-androgen. It helps with hirsutism and acne. It helps with reduction in hair growth by 40 to 88%, which is honestly like life-changing for a lot of patients who have PCOS. It's usually used in combination with combined oral contraceptives, but it's okay if you don't use it in combination. The dose is 50 to 100 milligrams twice daily. However, with this medication, you should reassess every 6 months in order to make sure that the dose is appropriate and you're getting the effect that you need to get out of the medication. You want to avoid this with drospirenone. Drospirenone is a drug that is an anti-estrogen, and that kind of just counteracts what spironolactone is trying to do. Next, if the patient has poor renal function or variable potassium, spironolactone can cause changes and increase spironolactone. And pregnancy. I know that our older patients are not going to be getting pregnant, but it's important for us to know that if someone is of childbearing age and getting prescribed spironolactone, that there is a teratogenicity risk for 4 months post-treatment. Our next drug is clomiphene citrate, and the purpose of this is to induce ovulation, and not specifically in order to conceive all of the time, but it is like nice to use this drug just to get the cycle back on track. So this helps with conception, and it also helps with issues caused by the hypothalamus that causes anti-estrogen effects. So the dose for this is 50 milligrams daily for 5 days. And you'll initiate this on day 5 after menses if your patient still has one. And then you may titrate up to 150 milligrams daily. Some adverse effects that patients may experience are nausea, vomiting, bloating, multiple gestation pregnancy. So by that, I mean that with this drug, patients are at increased risk of having twins or triplets, which is really interesting that a drug can cause that to happen. And lastly, some additional agents. The purpose of these agents are to cause induction of ovulation. Some of the drugs that you will see are dexamethasone, which is used in combination with clomiphene, some gonadotropins, ovarian drilling, as well as some drugs for in vitro fertilization. So let's wrap this all up and kind of apply what we've learned to our patient case. So back to Miss Crowder. She's having that increased hunger, urination, and thirst 2 to 3 times per week, and it's increasing over the last 6 months. She's currently taking spironolactone 25 daily. We did talk about 50 to 100 milligrams, but if a lower dose works for you, then that is okay. And then we'll talk a little bit more about her labs on the next page. So the symptoms that she is experiencing are consistent with type 2 diabetes. And so the goal for this patient is to decrease her insulin resistance as well as reduce androgen effects. Some important vitals that we should look at for this patient is her weight, which is 190 pounds, her height, which is 65 inches. And these are important in order to calculate BMI. So her BMI is currently 31.6, which makes her class 1 obese. Her blood pressure is 116/73, which is great. For her labs, her fasting blood glucose is elevated, so it's 174, and her A1C is 8.7, which we would like to be less than 7% or even less than 6 for a patient who doesn't currently have a diagnosis of diabetes. And her lipids are all basically uncontrolled. For her renal function, her serum creatinine is good and normal, and all other labs are within normal limits. So for Ms. Crowder, one, we want to focus on weight loss. So like we talked about, the first line is that 5 to 10% reduction in weight. So we really want to counsel her on her diet and understanding what foods are good for her to eat and which foods she should avoid, as well as helping her understand what physical activities work best for her. And maybe setting up a follow-up appointment with a dietitian, or even trying to assist her with some personal training. For her drug therapy, we should initiate metformin 500 milligrams daily, and we'll titrate that in 5 days. So we talked about making sure that our patient is on 500 milligrams 3 times a day, but we don't want to start at that dose. We want to start low and go slow. Metformin will assist with her weight loss, and we also want to counsel her on the GI upset that she may experience. Then we want to follow up with the patient in about 4 weeks to assess her weight and blood glucose levels, and we can assess her labs in 3 months. Another thing that we could consider at her follow-up visits are initiating statin therapy or high intensity statin to help with her cholesterol being uncontrolled, and doing some other things. However, you don't want to start multiple medications for a patient at one time. You just want to start one, see how that goes, and then tackle on the others to help with the additional disease states that they have, unless it's an emergency situation. So to summarize and basically wrap this all up, PCOS is increased production of androgen by the ovaries. It causes increased GnRH, or the causes are increased GnRH, insulin resistance, cardiac or metabolic comorbidities, and also genetics. The effects on our elderly population is the long-term effects that are associated with the cardiometabolic diseases, cancer risk, and other PCOS phenotypes that don't go away as our patients get older. And for treatment, the first line treatment is weight loss, but all of the other treatments are patient specific depending on what their life and their health permits. Here are my citations, and what questions do you have for me?
You might not have any. Did you say, I wanted to make sure I heard it correctly. Earlier you were talking about ovulation, which I know all my seniors should not do, but did you say 24 triplets?
No, I said that with, I think it's clomiphene,
Yeah.
patients are at increased risk of having like multiple gestation. So
Okay.
basically just having twins and triplets while taking this medication.
There was just enough noise outside of this room, so I was glad I was muted, that I'm like, I missed what you said, so thank you.
I hope nobody has 24 triplets. That would be insane.
I said, oh, wow. So does anybody have any questions for Taylor before I let her off the hotspot? All righty.